All right. Is this working okay? Okay. Hello, all. Um, I think we'll go ahead and get started so that we are on time. Welcome to this week's seminar, and I'm really happy to welcome Manfred Laubichler. And he is a SEM faculty member and actually has many affiliations here at ASU and beyond. But I'm really excited to hear about some of his group's recent work on valley fever. So I will let him take it away.
Okay. Thanks, Anne. I used to be a faculty member here at Source, but I got fired. Long story. What happened wrong here? Further down? Okay. That will be a long story that requires ethanol. But I'm at ASU. I'm the director of the School of Complex Adaptive Systems that almost nobody knows exists, least of all the provost, which is okay. And the Decision Theater. And that's a facility that even fewer people really know about. And that's a shame because it is sitting what ASU calls between the research space and the solution space. So the Decision Theater builds decision support tools based on data and scientific models to advance decision making. And over the last several years, last 2 years in particular, with the establishment of ASU Health, the Decision Theater has now a co-equal branch of activity that is called the Decision Theater for Health. So we are very happily and increasingly active in the health space. And so what I'm giving you today are 3 nuggets of research that goes on between the Complexity School and the Decision Theater, and one of them also within the center here, because Ken and Carlo are a major part of this project on the ADAPT project from ARPA-H about modeling cancer cell evolution. So a few vignettes about what's going on, and ending with an invitation for everybody who has projects that move from the strictly academic to the impact phase. That's where Decision Theater resides, and we can talk about what we can do in collaboration with you in many of those areas. So let me start with a little background. So there are 4 parts to this talk. First is background, then is the 3 cases. But where we are living and why ASU actually does have a School of Complex Adaptive Systems is that the presence, and particularly the future, one of the main challenges is what I call the crisis of complexity. And the crisis of complexity has many dimensions. I highlight 4 here. The first is that we have created an increasingly complex world that we no longer understand and cannot control. And a lot of issues related to environmental issues, climate change, but in particular also health and healthcare fall into that category. Now, why is this a problem? Because we have organized a science that is still organized on disciplines that emerged sometimes between the Middle Ages and the 19th century, and that do not map on the complexity of the challenges that we face. So we have a scientific and academic enterprise that is not mapping the challenges that we face. And then we have an education system that sits on top of that. So we have difficulties training the next generation to be more alert to what is actually needed. And we have a governance system that is basically, if you are generous, stuck in the 18th century. Now we are going back to sort of archaic times of a governance system, but that's a different story. So that's the crisis. That's one of the contexts that we face. There's another context. Since I'm a pretentious European, I have to do things like this. So there's this famous painting by Paul Klee, The Angel of History, and Walter Benjamin wrote a fantastic quote about that. And what it basically states is that our big problem is that while we are inevitably be driven into the future, our glaze, our orientation is into the past. We are not really looking into the challenges of the future. And science is a big problem of that, because in the past, that's where you have data. That's where you can validate models. Going into the uncertain future for scientists seems to be a psychological problem. But that's what we have to do if you want to address the challenges of today. Now, those challenges have a lot to do with that we live in the Anthropocene. You're aware of that concept. The Anthropocene is basically a new geological era, even though those funny geologists have voted it down, but forget those rock biologists. And it states that right now, us as humanity have become the major force impacting every process going on that planet. Now, of course, we didn't get there out of nowhere. In order to understand how we get into the Anthropocene, we have to understand what is the long and complex coevolutionary history between us and the planet that gets us there. We do a lot of research in that area, so if you're interested in that, talk to me. But as a consequence, we are currently shaping the planet at global scale, leading to the fact that we have left what some planetary scientists call a safe operating space for humanity. And while they look at it primarily through the lens of what I call the gospel according to Johann, so Johann Rockström, one of the major researchers, head of the Potsdam Institute for Climate Research, and was in the habit of being basically a modern-day prophet. So he has the gospel of Johann here. We are no longer in a safe operating space, which means we have transcended many of what they call planetary boundaries. And while they are primarily focused on environmental boundaries or challenges, of course, health is a major part of all of those, implicitly or explicitly. So what that means is that this dynamic basically has been leading to new global challenges that contribute to what's called systemic risk and system failures. So basically, every system on this planet that you look at right now, in my somewhat radical interpretation, is currently within a failure dynamics. We are heading to collapse of all those systems. That's why it's completely stupid to talk about conservation. What do you want to conserve? Everything that's already failing? We have to sort of figure out how to regenerate the structures and abilities of those systems. Okay, that means we need some new ideas in science. Now, a few minutes about the background and what kind of evolutionary theory drives all of that and is needed, because this is, after all, the Center for Evolution and Medicine. So you have to suffer through a few minutes of novel evolutionary theory here. So if you think about what went on in the 3.8 billion years that led to the Anthropocene, it is a story of major evolutionary transitions. Now, those are some of them: origin of life, cellular life, multicellular life, and so on. But what's interesting from a complex systems point of view is that every one of those transitions has some core features. When you undergo an evolutionary major transition, it changes the organizational structures of those systems, sort of different layers of complexity that affect the energy distribution within those systems, the way knowledge or information flows, and also the way material flows. And this complex systems perspective will become very relevant when we talk about the concrete examples, the concrete medical examples. What happens within every major evolutionary transitions, even with some of the more minor one, but why bother with them when you can study something interesting, is that you see emerging layers of complexity and feedbacks that govern the structure of that system. And so the Anthropocene, or the associated concept of the technosphere, which is all of our infrastructure, is basically the last of those major evolutionary transitions. To just give you some since I don't have time to get into that, but as I said, we do a lot of research in that area. What is the technosphere? Sort of, it's all of our support structures, infrastructure, technologies. Now I'll give you a few numbers. Every one of you, that means every individual on this planet, carries the weight of the Brooklyn Bridge on your back. That is the per capita contribution in terms of simple mass of the technosphere. 30,000 tons. And in terms of energy consumption, 10,000 years ago, when we were more or less a biological species, we behaved like we would. There is a scaling relationship in metabolic scaling, scales to the power of 3/4, and we are right between a mouse and an elephant. That means our daily energy consumption base metabolic rate was 90 watts. Currently, every one of you base metabolic rate of a socially extended individual with the technosphere, 11,000 watts per day. 2 orders of magnitude in less than 10,000 years. How did we get there? And it has a lot of consequences also about how it affects our health. So to understand that, there is a big theoretical challenge, and when I'm not running things, I still pretend to be a theoretical biologist, so you have to listen to that. So the challenge really is to fully integrate our understanding of complex systems with our understanding of evolutionary dynamics, which hasn't happened, really. And that's a twofold challenge. Conceptually, how do we actually think about evolution as the transformation of complex systems rather than sorting out alleles within a population? And the reason why it's not just a conceptual challenge is that it requires some mathematics that doesn't yet really exist. That's why we haven't done it, because the math is really hard if you want to do that. So to illustrate what's really in a very sort of top-level framing, this is sort of the standard evolutionary framework that most of evolutionary biologists operating under. And so you have heredity, you have some complex system, you have realized that development plays a role, it's called this evo-devo. It actually somehow produces then a phenotype. The phenotype interacts with the environment, and that gives you the only feedback mechanism in that system, which is basically natural selection or any variant thereof. And the accounting of evolutionary change happens on the level of allele frequencies. That's sort of the standard view. Woefully inadequate, to say the least. So what that has, and we sort of don't have to get into this, you know all of that, selection is the main feedback mechanism. The problem of the origin of variation, we have outsourced to physics. Once we discovered that DNA is a very large macromolecule, you can calculate the average mutation rates. Okay, problem of variation solved. We already talked about the temporal sequence of change in allele frequencies. It has an implicit assumption of optimization in there, comes through selection. And the way you describe this is with ordinary differential equation. Okay, we know that math, it's doable. And it's especially doable because everybody in evolutionary biology has a preference for equilibrium dynamics. So we only look at a few epsilons from a fixed point. That's when the math is simple. If you go further away, it gets more interesting. But that has been ignored by and large. So what's an alternative? We call that extended evolutionary theory. And you see it starts the same way, but it realizes that there are a few more feedback mechanisms that we need to consider. One is that phenotypes actually actively construct their niches. So niche construction is an important part of it. And if you actually look at not just inside a phenotype, but inside the constructed niche, you get dual or multiple inheritance systems. Because fun fact, you don't need to have a DNA to have inheritance. We did the whole mathematics of population and quantitative genetics having no clue about what the substance of heredity is. It's just persistence through time. So you get a lot of persistence in the features of the constructed niche. And what's then particularly interesting, how they feed back into the complex system. So those are the emerging new feedback mechanisms. We call those internalization. There is one directly causally affecting development. I'll give you an example, big example from evolutionary medicine. So we have externalized over the last 250 years over 4 million chemicals that we produced through our knowledge system and dumped into the environment without thinking what they are doing there. And you're aware of one of those category of chemicals called endocrine disruptors. They go right in here and affect the regulatory mechanisms of development. And I can tell you 10 hours of stories like that, of this sort of direct feedback of internalization from things that we externalized into our niche. And it can even go all the way into the hereditary system, but it also changes, of course, the selection pressure. So this is a rough cartoon sketch of what type of additional complex systems feedbacks you have to consider if you really want to understand what evolution is currently. So if you then apply that, and we are working in all of those systems to some degree, I work primarily with cell types, character evolution, and then now evolution of knowledge into technosphere. If you want to talk about evolution of cancer, talk to Carlo. But that's the whole framework where this more complex representation of evolutionary dynamics plays a big role. So I said that's sort of more on the conceptual and empirical side, and I said the other challenge has to do with developing a mathematical theory. So that just was published last week. So we actually worked quite a bit in developing a framework for this type of more complex evolutionary system. We call it the extended life cycle. And I spare you the math because it is challenging. But this is what this math allows you to conceptualize. So you have basically multiple levels of organization. So you can go from the genomic to the cellular to any number in between to the environment. Doesn't really matter. In each of those layers of organization, you have ongoing dynamical processes. That means you get time series data of what goes on there. And so far, we have treated those layers mostly in isolation. But if you remember the picture that I showed you about the conceptual framing, what's really important are identifying the various feedback mechanisms across those levels. And that's what this new mathematical framework allows you to do. So if you're interested in that, talk to us. We can walk you through. It would be absolutely fascinating to get many more use cases to apply that framework towards and what you can do. So when we first, submitted the paper, it took them forever to find reviewers because it's a very mathematical paper. Then they found reviewers, and to my big surprise, they were not stupid, but annoying. Because then they insisted, well, this is a nice mathematical theory. It would be great if you have a concrete example. So, well, mathematics is true. What do we need an example? Okay, we did one from an ecological setting, and we are applying that together with Carlo and Ken, also heavily in that cancer evolution project, and give you a few results there. So this thing is now there, so we have a solid mathematical foundation, and just to show off, this is how that looks like. You see it's not a simple ordinary differential equation, but never mind. And with that, you can actually really provide a better explanation for major evolutionary transitions that focuses on the transformation of complex systems. And so now there is an interesting provocative statement about how we actually conceptualized evolution. So you all grew up in the very Prussian doctrine by Ernst Mayr that evolution is about population thinking. Crap, population thinking is completely boring. Evolution actually, if you go back into the history of evolutionary thinking, started out with trying to understand the transformation of complex systems. And ultimately, Darwin knew that evolution is not one but two questions. The first one is the origin of variation. How does that happen? And the second one is what happens to variation once it exists in a population. Since we have spent the last almost 200 years focusing on what happens with variation and figured out how that works, I sort of become a little polemical and say this is boring. Let's focus on the more interesting question, namely the origin of variation, which means you look at evolution as the transformation of a complex system. That's what also that mathematical theory allows you to do. We can then actually explain the origin of variation and innovation. We focus more realistically on what's actually mean that evolution has a history and not just time. Because if you represent evolution with differential equations, you only have time. And you can actually run it back and forth, simply mathematical truth. But what we all know about evolution, it has a direction. So it has a history. And that you get more easily with this framework of understanding evolution as transformation of complex systems. Okay. So if you then look at, we can chip that, this is sort of how this applies to understand a major evolutionary transition with the notion that they all basically introduce a new platform, but that would be another story. That's more interesting for what we're talking about here. Sort of a little conceptual history of science. There's a parallel trend in our understanding of disease and our understanding of evolution that emerged in the case of disease over the last 2,500 years and the case of evolution over the last 250 years. So it started out with a recognition that we actually are dealing with complex systems. So the Hippocratics basically defined disease as balance, as imbalance, and health as balance. And what you had to do was restore balance. The way they did it was interesting, but the concept was pretty sound. Then, starting in the 13th century, in particular, a trend emerged that began to understand disease through its localization. If you cut open corpses, then you see which organ is transformed. So the idea of a localization of disease that got all the way down to the molecules. That's what we are dealing with now. The localization was great because it emerged a certain paradigm of causality. And it's called the one disease, one cause paradigm. So if you identify in a very narrow way where the disease is localized, you can identify the causal reason for that disease. That gene has a mutation. That molecule is transformed. And so it followed with the scientific paradigm of reductionism and led to a sort of a single cause understanding of disease. That was sort of roughly the history of the last 2,500 years, except we now realize that that's not true. That we actually have to try to work hard to bring in those complex networks and difficult causal relationships into our understanding of disease. And the same, as you can see, happens in the history of evolutionary biology. So where we are right now is basically here, that we need to become modern-day Hippocratics, in a sense, trying to really understand disease as a consequence of complex networks and complex systems. Final sort of conceptual framework, and this is what follows from that in a broader background, and that we call that the regenerative paradigm. So this is the situation right now. And it's true not just for biological systems, but that's what the slide says. Every biological complex systems that you can think of and look at, I would say, is currently within a failure dynamic. And that is a consequence of the Anthropocene. But if you see what actually goes on among complex systems, in particular biological complex systems, you see an interesting phenomenon. So they are all the product of evolution. As a consequence of that, they're all pretty robust, because if they wouldn't be robust, they wouldn't exist. So the currency of evolution is persistence, which requires that in the course of evolution, those systems develop mechanism that makes them pretty robust against a whole range of perturbation. But of course not about everything, because if you would engineer something that is completely robust, it by definition can't evolve anymore. So there's an intricate balance between evolvability and robustness. So that means the systems are not 100% robust. So, but they experience continuously internal and external perturbation, which then at some point reaches a kind of bifurcation point where those systems begin to break down and enter failure dynamic. Part of that is an important part of evolutionary processes, because if it wouldn't die off, there would be no evolution. So old people need to disappear at some point, you know. Looking in the room, I'm the first. But what's fascinating is that since this is happening throughout the life cycle of an organism and they don't collapse immediately, there is a pretty powerful potential for regenerative dynamics in those systems. And I think that's what we basically have to understand. This is where we have to be in. And so if you want to have an example about what we mean by this kind of regenerative dynamic, again, talk to Carlo. Because what they basically discovered by looking at cancer treatments, not as the kind of reductionist eliminate everything, but find an appropriate new dynamically stable equilibrium between the cancer cells and the normal cells, that's part of that regenerative paradigm. And that's what we need to actually do. Okay, so that was background. And as usual, way too long, but you know, it might have been entertaining. Let's go to the three examples quite quickly where this way of work is showing itself. So the one is the Cancer Evolution and the ADAPT program. As I said, Ken, Carlo, myself, Stephanie Forrest, and a few others are part of that. And one of the challenges that they gave us is trying to figure out in a predictive way which treatments lead to resistance and which treatment lead to success, given whatever input we get from clinical data. That's sort of a holy grail for cancer treatment. It's a tiny problem. To address this problem, and this is sort of the ridiculous thing about how money gets distributed in science, the whole program is 140 million. Mostly useless clinical trials, And how many did we get? 5 to do all of that conceptual insight. Anyway. And so that's where we applied that framework of extended life cycle, running through that very quickly. So exactly, the objective is to develop and apply these new types of mathematics to predict whether resistance or success might happen. Why is this a great example for this type of deep Gaussian analysis and the nested extended life cycle? Because the data are at different ontological levels. So you have data about the genome or other molecular pieces of information. You have data about the phenotype, what is the actual tumor progression, and even not just the tumor as such, but then more interestingly, what are the different cell lines into that tumor and how do they evolve? And then you can even expand that to, social determinants of health. They don't give us those data, but in principle, we could do that. So it's this multi-layered framework where we have all those different time series data, and we are trying to use that framework to come up with a predictive model for that. So, deep Gaussian processes. We don't have the time to really get into this. If you're interested, talk to Carlo or me with how that works. And we actually have developed, based on existing data, because the clinical groups haven't given us any new interesting data yet, but there are data out there, so we use that to fine-tune that mathematical approach, and it works. Okay, pre-processing. So the performance metrics are pretty good. We don't have the time to get into this. We can do that in Q&A or others. But this is basically what the purpose of this is. So if you have this framework and you then run, and it's kind of a machine learning or AI type framework ultimately, and what we want to do, and I can do pretty successful, is given all the information that we get about those patients and their progression, can we predict from the beginning in which bin they fall into? And the way this has traditionally been done is sort of high risk, low risk, medium risk, which is related to the survival rate based on a cancer treatment. And that's what you basically want to know ahead of time. Given a certain treatment that you are contemplating, will that lead to a good outcome or a bad outcome? And the ultimate goal is monitoring treatments, but again, the clinical trials don't really get there. Carlo knows more about how ridiculous this is than me. But the ideal would be you start and you monitor and you can correct. That would sort of be the ultimate purpose of this model. I think we know how to do it mathematically if we would get the right kind of data. So, yeah, there's another one of those. And then if you look at that model, you can then identify some of the top risk factors that are associated with those. So this is, again, this is not something that is completely new that we do. This is basically demonstrating that our methodology actually is an improvement over the existing methodology. So the questions have been out there, the results have been out there. We just get a more fine-grained resolution than the traditional statistical approaches that have been deployed. So you can identify what's going on, tumor size, age of diagnosis, certain principal components that have something to do with what kind of genes are actually affected in the particular tumor or cell line. So this all works pretty well. We can recover that and get some very interesting results. Again, this would be a very technical piece, but we can do that if you are interested in. So the next step is in that project. So right now we are looking at the data that we have, and they are pretty phenomenological in the sense that it is data about objects at different ontological levels. But what you really want to know is how can you then reconstruct the mechanistic pathways that drive that? And this is where our work intersects with Carlo and Ken. I mean, that's the goal, is basically to figure out what are the pathways of resistance, rather than just what are some markers for resistance, to get a real deep causal understanding. Okay, so much for cancer. And we published a paper that then I didn't see that people actually read those papers, but Anne did, about valley fever. So what are you doing with valley fever? I want to know about this. So here we are with valley fever. And that is a sort of complex systems approaches, but also already with the decision theater, because there is a very practical application for why we are doing that. So there is the better understanding the causality of valley fever, but also actually having an impact. So this is the paper if you're interested. But what we did, we wanted, the question is, with valley fever, and to give you a little bit of context. So the monetary cost of not being able to effectively diagnose valley fever here in Arizona is over $800 million annually. So there is an interest. That's just the interest that matters. Never mind about people dying or things like that. Who cares? No? The monetary cost, $800 million. What is the reason? Because the symptoms that you have when you present yourself to a doctor or an ER are very ambiguous, because there can be any number of respiratory diseases. You can't distinguish this. So you would have to test, because valley fever is a fungal disease. So if you do the usual, what the doctor does without thinking, give you certain antibiotics, it doesn't do shit. And just prolongs the disease and makes it worse. Just to another sort of monetary number, those cases that go really deep into being problematic, either people die or barely recover, the average cost of a patient like this is $1.4 million. So there are reasons to figure out early what you have. And So that was the challenge. So we needed to identify, based on data that are out there, is it likely that a patient who presents with certain types of symptoms has valley fever? Because, of course, you could say we can test everybody, but then there is another monetary constraint. Then you get with the insurance fights and your doctor, why do you ask for a valley fever test? What's the evidence? Blah, blah, blah. So what we did, based on the understanding of valley fever, we introduced, we're the first to basically introduce the deep learning system to make better predictions about whether a patient in a particular location at a particular time is likely to have valley fever or not. So in other words, whether it pays to test. That's the challenge. So what are the data? So valley fever is an interesting disease. There's the spores of the fungal, they're in the soil. And there are certain conditions that makes it more likely that they are in the air and you can breathe them in and get infected. So there are a couple of environmental reasons that we sort of got all the data, sort of weather and climate, air pollution, drought conditions. That list is being expanded and also with an increasing geographical resolution. So, and what you want is basically figuring out which of those might be the best predictor or which combination of those might be the best predictor. And so for that, we developed this model, deep learning model. It's technically called a long short-term memory. A funny contradiction, but what it does, and this is why this is a very interesting methodological improvement, we don't need a detailed causal understanding of what is the main cause of valley fever. I mean, that's what everybody was trying to figure out, and then they created a model that has a lousy fit with the actual data because it's a complex system. This reductionist approach doesn't really pan out. So what this deep learning model does, it doesn't care. It learns from the data streams that you put into the model historically and adapts to what is the best prediction in the near future. So what that does is basically allows us to train the model on a sliding scale of the last 120 days of data, environmental data and incidence data from the hospitals. And it adapts and makes predictions on a 10-day framework or a slightly different model on a 30-day framework into the future. Why does that matter? Because that is exactly what the next step that we're currently developing with our clinical partners is basically a simple tool or almost like a traffic light issue that you can have in ERs. Okay, what are the valley fever conditions? Are they green? Okay, must be something else most likely. Are they red? Oh, we better test. I mean, that's sort of the implication where then the cost savings into the medical systems come in. So the way this works, so we then sort of, there's the training set, and you see that the training period, the confirmed cases are green, our forecast model is red. You see that actually is a pretty good fit. And when you can see it here, that's why we zoomed in. If you then go into the 10 days into the future, you see that the fit is also good. This is a much closer resolution, so don't worry about the distance. But the actual number of cases that you predict are less important that you predict very accurately the trends, because that's really what matters to determine what might be going on in the future. You can always increase the accuracy, but if the model predicts that 99 out of 100 or 95 out of 100, doesn't really matter as long as it can tell you the risk is going up or down in an effective way. Okay, so here's then the 30-day model, similar issue. Also not as accurate, but also pretty good. And so actually, just this morning, we were in a meeting with people from Cigna Health about this, and so the discussion was then, okay, the 10 versus the 30-day model, might actually target different elements of the health system. So the 30-day model is somebody who actually is responsible for the supply chain of hospitals wants to know, because they need to order certain types of supplies. And they are fine with a less accurate model, if it predicts the trends very accurately. The more detailed 10-day model is what you might implement in the emergency room, because they really need to know more accurately what they should be doing. So those are different dimensions of how this can have an impact. So what we are doing next is basically increase the number of data, particularly including more air quality data that we are now getting. Also better clinical data, and expand the geographical, focus on the geographical resolution. So why can we do that? Because we did another project where we basically created a valley fever risk or suitability index. That means everything that is red here has the most suitable condition for the fungus and the spores, and that gets refined. So that means it already helps you making educated guesses about where geographically that risk is higher. And that also gets updated. It has to be then combined. This is work that Dave Engeldaler is doing, who they sort of realized that a big way of how those spores spread is that they infect burrowing mammals, and they run around and die, and that becomes sort of the source of another big fungal location. So you need to know also dynamically where are those species, where the concentration of those species, because that also contributes to the suitability index. You can then integrate those two, you get a more accurate resolution. And then we combine that, which we are now getting more specific location data from clinics, so that you can actually map this. And you see our original forecast model has the contextual environmental features, but it also has the history of clinical cases, so we can do that more accurately geographically, so that not every clinic in the valley, for instance, gets the same warning symptom, because it will be different. And then the next thing is what we just developed right now, since a lot of this has to do with when the soil is actually perturbed, as a particular digging and building in our location. And previously they looked around and said, well, where are building permits and things like that? So we are analyzing real-time satellite data. So we basically developed a learning model that, we get those planet data, and we have an algorithm that immediately identifies when and where are they digging, because that factors into the risk calculation of valley fever. So that's the valley fever work, and you see it's understanding the science, developing some novel approaches, in this case sort of deep learning approaches, but then in collaboration and with the specific purpose of having an impact. And so our partners here are health systems and insurance companies. Okay, final study, quickly, because we just started this. This is a project that is funded by the Piper Trust. And it has a lot to do with the establishment of ASU Health, because ASU Health was established because Arizona does lousy on health rankings. And so politicians said that we need to change something, and ASU can no longer not be part of that. You have now a medical school. Of course, Michael was just waiting for that order. And so now we do have a medical school. And now one of the big challenge, both for ASU Health, but also for the state, is how do we understand the health metrics and why they are the way they are, and what can we do to improve, and how do we measure improvement? So, as I said, we will have the first part of that project will be finished in a couple of weeks, and then we enter the phase of stakeholder engagement. So for that, let me spend 3 or 4 minutes to introduce you to what the decision theater is. Has anybody been to the decision theater other than Carlo? You don't count. Ages ago. It's completely different. So the decision theater approach. So what is it? We have sort of a mission statement. This another sort of anecdote. I was charged to retool the decision theater and sort of headed a typical academic committee. I thought I was done. So we made some recommendation, and then Michael turns around and says, "Oh, you're going to run this now. You know that." Do I? Okay. So we redefined it, and the point is basically to get the best insights of science and relevant data and translated them into tool for action, especially with the next caveat, at a pace the real world requires. That means we are dabbling more in uncertainty than some scientists would like, but we have to. And what we learned is that you can't do that in isolation. You actually have to involve your stakeholders and clients from the very beginning. So those are the two dimensions of the decision theater approach. The way it works, it has sort of this method that is an iterative cycle between data analysis and modeling, and this is where all the science comes in. Technology development, which we continuously do, and then most importantly, what we call human-centric design. Because you have to know who your clients or stakeholders are and how you present materials to them so that they understand it and can act. This is a major part of what we are doing here. So there are different, and we are most known for our 7-screen environment. This is the theater approach there. And different models at different layers of complexity all the way to a gamified version that we had to build for the State Department. Because it strikes me as particularly peculiar about this country that the way ambassadors are appointed, basically you are friends of the incoming president and you have no clue where you're going. You can't even find the country on a map. And so the career diplomats said we need a tool that we can train our ambassadors. So we developed them sort of a decision scenario tool as a game for ambassador training. Just a range of things that we are doing there. Okay, so this is sort of this is where complexity comes in. We have a similar slide for health, but I put this talk together at 5 in the morning and I couldn't find it. So you have to be with the regional transformation, which is the other big area. So the idea is you might have a particular challenge. That's one that we do. Okay, build a model for the future energy system in Arizona, which we did. So it started, of course, more in sort of the technology, but it doesn't stay there. It goes into the economics, it goes into education, workforce, and all the other dimensions. So this is where complexity comes in. And if we have 7 screens, and now potentially we have N screens, because we have created a new software framework that is basically, mathematically speaking, a hypercube. From every screen you can jump to any more screens. But so you can actually represent that complexity methodologically. And so the same slide with health, you can fill in the blanks, what are all the different parameters if you try to build a solution for health. Just to tell you where we are, and so it's a global network. I have decision theaters at Hawaii, in Los Angeles, here in Tempe, in Washington, D.C., and in Berlin right now, soon to be in Bermuda. And in other places, we have long-term partnerships, such as the Mekong River, which is an ongoing 9-year project with the Mekong River Commission. So we are globally represented, just to see how that looks. So this is the main drum here in Tempe. There is a smaller version of the drum in Washington, D.C., actually literally 2 blocks away from the White House, so there's a lot of policy discussion there. Then we have a satellite in the Walton Center, because, of course, you can't expect from those people who are sitting there to walk across. I have to run back and forth now. It's pleasant, but do that in the summer. I know every path through every garage on this campus. But there's a satellite that is basically linked to this one. And our big innovation is we have a mobile version that you can set up within roughly an hour, and you can take everywhere. All you need is power and an internet connection. And it actually works. We designed it in such a way that it works outside. So if you, for instance, some of you do that sort of in tribal communities, and you want to have a discussion about health impacts, you can't expect them to come down here. You have to better go up there and meet the people where they are. You can do that with this mobile version. Okay, so this is now the context. So this whole health metrics project, and I didn't want to show you the mock-up slides because they don't mean anything. I rather extend an invitation. So what it does, first phase, is a health impact explorer, as we call it. So we are currently ranked 34th. We have all the data from the Commonwealth Fund that does that ranking. We know how that ranking comes together. We did a deep analysis and figure out how hacked the system, so to speak. So hacking the system means we can actually game the system. So the phase one is, in those 73 dimensions, we call it the magic wand phase. What if we would improve in this metric by 5%? What would be the consequence on our ranking? Or you can reverse it and say, if we want to become number 29, what do we have to do? Any combination of indicators. So this is the first phase. That will be done and to be explored in 3 or 4 weeks. Then we enter the second phase, and this is where the invitation comes in. So what we then do is we are bringing in different stakeholder communities from ASU Health, where they are part of us, but then, or they think that we are part of them. It's sort of debatable relationship. And then, but also, state health department, hospital systems, insurance companies, you name it, and to explore, go beyond the magical wand phase. We improve in this indicator by X. No, what do we have to do to improve that indicator? And also have a conversation, which indicators can we improve, or which are out of our control, and what strategies can we develop to actually improve those. So with those feedback of conversations, we then design the next phase, where we actually build models about what can be done in terms of changes to the system, and how would that affect the overall health outcome. So you will get an email once this is ready, inviting Sam to say, okay, come to a session and think about, and explain what the indicators are, and start thinking about what do we know and what can we do to actually suggest improvements in terms of, we call it then drivers, that would affect one or many indicators of the system, and suggest what that could be, and then we build the decisions here, the models, scenario models, what the consequences of that would be. So this is how we are operating, and this is sort of the next phase, and so great timing with the invitation, because I really think it might be, for us, very relevant, but for you, probably curious and interesting to sort of explore things in that way. Okay, and with this, I stop. And I did not go over time, which is a first.
Work now? Okay. While I'm walking over that way, I have a quick question. When you're looking at, for valley fever, when you're looking at building patterns, do you also look at like plowing? And,
So we've developed an algorithm that we can infer everything from those satellite data. So it's digging up for building or currently plowing for cotton. We know all of that.
Yeah, cool. Great talk, Manfred. I think we have another layer of data we can add to your valley fever model too. You mentioned like the burrowing mammals sort of generally. Like my lab's been looking at sampling desert rodents across the valley, and it seems that there's some
so not the ones above the soil too.
Yeah, well they burrow, but then they live above ground too. But then it seems there's non-random which animals that tend to not die from the valley fever infection, that are like more likely to be the reservoir host. Mm-hmm. So there could be some nuance.
So they can run further than the ones who immediately die. Therefore, spreading the disease more relevant.
And yeah, they really need to die underground and then spread into the soil. Like the cocci will eat the animal, and then the digging happens. Yeah, so that's more just a comment.
Yeah.
The question I have is about the first part of your talk, and thinking about the extended evolutionary theory dynamic. You're kind of emphasizing the selective component But what about the population size variation and how that would affect the strength of?
So we actually ignore the selective component, because we know how that feedback with selection is, and also population size. I mean, that theory exists, but it is primarily devoted to trying to figure out what happens to variation once it exists in a population. So what we are interested in is more the mechanistic one. What happens, or what does have to happen so that you transform that complex system into a new state? This is sort of a preference. As I said, Mary Jane West Eberhard, when I first sort of said, well, there are two sides to Darwin's question, she was nodding, and I said, well, one is boring and the other one is interesting. She was about to kill me on stage. But, it is polemical because they are, of course, complementary. And we are focusing primarily on the component that has not been addressed yet, and this is this complex system transformation issue. But in that diagram, when I had this one feedback selection, I said, well, this is sort of an abstraction. Of course, it's not just selection. There are all those other contributing factors that influence evolutionary dynamics that you just mentioned. So yeah, you have to have, but it's one kind of a feedback. It's a generational feedback.
I guess I'm just thinking that you could add that in, and that because selection becomes very weak when you have small populations.
Right.
So when you have like these population dynamics, like boom and bust, it changes the whole equation, I would think.
It changed not from our end, because the way we look at it is, let's say, if you put the generational layer in, sort of the evolutionary layer. We basically take some real observation data, and the pattern of change, of course, will be affected whether you have small or large populations. So that will be picked up by this deep learning algorithm that's also behind that problem. So we don't have to sort of specify, okay, we are now studying the effects of whatever, small population or something. No, we study whatever data there are, and we break it down with this learning algorithm. So where we use the ultimately, machine learning, most elaborate version of statistics, basically. But we use that to make inferences about what pattern is actively happening right now. And the interesting thing of this methodology is that if you have time series data that are long enough, and as I showed with the Coxie data, that system learns and also changes the interpretation of what is going on, because you always look at a certain window, make predictions. If the prediction doesn't pan out, you learn that there's now something else going on. So if you have data, for instance, where there is a population of a certain size, and then for whatever reason it crashes, and then it grows back up again, if you have long enough time series data, that an analytical framework would pick up on the level of population that is primarily driven by selection, then it's primarily driven by drift or some other factors. Size increases, selection kicks in again. So we could pick up that change in underlying mechanism with this model.
Cool. That's great.
Manfred, great talk, and it's great to see all those different aspects. I guess I have my main question is really about this last part, and I think it's great that you're addressing the question of what parameters can we, or what aspects can we impact, and which of those are going to be most effective in terms of getting the biggest bang for the effort, whatever. But it also, your point about gaming the system brings up the other meta question about, do we have the right metrics? Are people happy with that? Because
the answer is no. But the problem is that everything that rides in the healthcare system and funding decisions and bragging rights and you name it, that Commonwealth fund data are around for almost a century. They basically are the status quo. So we have to start there. And of course, we are working actively, and this is also a reason why we want to invite you guys in and saying, oh, there's a parallel development. What are they measuring and what they're not measuring? And ultimately, they are very good in measuring the performance of a health system. Now, the performance of a health system does not correlate very well with the actual state of health. And this is the same as if you then talk to insurance companies. They nominally say that, yeah, we care to improve the health of our insured population, but they are honest enough that about 2 nanoseconds later they tell you ultimately what they care is the bottom line. So that should amuse us. We might get an interesting another ARPA-H project if they set up this program. Because they talked after we had them in the decision theater. So they came back to me with 2 program officers. We're thinking about a new program. And what we want to do is create models that measure what's going on out there in the disease burden state and intersect with hospital systems so that they can optimize their supply chain, their ordering, and their staffing decisions in real time. Normally we can do that. And then there comes the funny part. Okay, and can you do that not rely on the traditional public health data because we don't know whether they exist in the future? So they are interested in proxies, such as satellite data, social media analysis, and everything that we can do to basically create a predictive model with the technologies that I showed you. And then you say, and don't, the warning, if the program gets approved and, we put in our next proposal, you say, don't talk too much about health. Talk about the bottom line. That's the reality that we live in.
So the other question I had is a smaller one about the valley fever sort of indicator for the emergency room. It seems to me that you only need a 1-day predictor just to tell the emergency room what the risk is for today. Is the 10-day because there's a lag in reporting from the other locations, so you don't actually know? So
the 10-day, a couple of things. First of all, if you talk to the people who run those things, that they are not changing their behavior on a day-to-day basis. So you have to give them some framework to orient, but also because in order to be accurate, how quickly do you get the data in? That's another consideration. Yeah.
Thanks, it was a great talk. So I was curious about the project on cancer, where you're looking for what treatment regime would be the best. And this is, I always talk with Carlo because we have very similar questions. He works on cancer, I work on controlling mosquitoes. Mm-hmm. Same problem. But also I always joke that cancer is way easier because every individual, which he doesn't agree with, but every individual is like this nice contained evolutionary package, right? You start with a naive population and you end with an evolved population. In public health, usually it starts somewhere in the middle, right? Like it's 2025 and whatever happened, and that's the past and we can only, we can predict the future, but we can't go back to 1950 when we started using some of these chemicals. And so so the question is, one of the things you're saying, at least in the cancer, like we can model this as long as we have the right data. Mm-hmm. So what is that data that you're looking for, I guess, in the cancer system, but also in general, like how, I'm curious about your thoughts, like how would you do this then in a public health system where obviously, what kind of data is important?
Yeah, that's a very good question because what's behind why I told you those 3 stories is because in each of those stories there is a certain formal or mathematical tool that we developed to approach those questions. And so in a way you could say, well, we are now in the classic have hammer looking for nails kind of scenario. But no, we're actually adapting our tools. So in the cancer case, the data that we ideally would have would be, and the ones that we easily get are they do a genetic profiling of the patients. They do some, and Carlo knows more, they do some single cell sequencing data about different cell lines, sort of. At least they claimed they would do it. And then you get data about the clinical observations, and there we already run into a problem, which is sort of funny because we would ideally want, 7 biopsies over the course of a patient. And then particularly the Mayo people say, well, you can't do that. And when we ask them, did you ask the women? It's a breast cancer study. Oh no, we can't ask them. So the data issue is is a big one.
The patients will actually do it.
The patients will do it if you ask them, exactly. No? So basically, let's say genomic, molecular, cellular, phenotypical data, and what we would like to add, but then you run into those HIPAA rules and things like that. We would like to add environmental data, sort of the whole exposure. So if you know where they live, we can pull in a lot of the environmental exposure data, and then would add another layer that would be very interesting. And anything in between, you could ask them their diet, even whatever might be relevant. The framework can handle that. So there, the tool is there. Now, with your question about public health and in the past, so we are now starting an intriguing project because we had a decision theater event in Science Week in Berlin, and we invited all the crazy creative people. What can you do to enhance that? And the most compelling group that we are now working with came up with an idea: can you use decision theater to sort of create historical what-if scenarios? So backcasting. And they were thinking, but they came from museums and saying, oh, this would be great for museum and education. And saying, okay, good. But it's actually also interesting for public health, because if you have good data about historical events, and we translate that into that kind of decision support framework, and you could play through scenarios based on what you know, sort of what if we would have done that? And it would be, it would sort of greatly enhance the understanding of possible outcomes, particularly in cases where they are so complex, we don't even know what the boundaries are of the system and things like that. So it might be very useful if you have some good historical data of outbreaks and things like that, to think about how to turn that into a historical tool, where you could say, well, if we would have had this already, or if we would have done this, what could we have prevented? Because also in terms of the PR component of that, if you want to make a case for certain types of intervention, those types of arguments, if they're credible enough, they are actually quite compelling. So let's talk about that. The Black Death, yeah. Well,
All right, with that, I think we probably need to say thank you once again.
well, thank you for having me.